better way to wind down the week than to do my first webinar, and I have the distinct privilege to have Rich Severin join us. Rich is a physical therapist who is currently pursuing his PhD at the University of Illinois at Chicago, and his focus is cardiovascular and cardiopulmonary considerations. And just wanted to welcome you, and thanks for taking the time to join us.
All right, well, am I live now, or?
You are live, yeah.
All right, so thanks for having me here, Chris. It's been it's an exciting topic, something I'm very interested in, and kind of merging the two. In addition to my starting this PhD this summer, I've in the midst of an orthopedic residency here and had completed a cardiopulm one. So you may ask, kind of on the surface, who in their right mind would do two residencies back to back in two unrelated areas? And the thought processes that I have is that we see all these orthopedic patients, and we tend to ignore the cardiopulmonary system, and I think it's much to our disservice. So a lot of the research and clinical practice that I'm interested in is trying to merge those two to see kind of how that affects outcomes and as far as safetiness and in our avenues for direct access. So I'm very happy to be here.
Well, it sounds fantastic, and I do think it's an area that's overlooked, especially in outpatient orthopedic and sports. So, that's an area that really the reason I wanted to bring you on today is, obviously folks know me through a lot of my work with runners and triathletes, and I always am wondering, what am I missing when an endurance athlete comes to see me? And, it's something that I know that I can do a better job in terms of screening, and just to get more familiarized with that realm of physical therapy. So what prompted you to get into this in the first place?
To this, as far as this practice pattern or research, or?
Yeah, just your specific focus between sort of combining cardiopulmonary with orthopedic physical therapy.
Well, as you might have heard from Scott and Will, some of my other colleagues, I am an insatiable reader, and combining that with having two really prolific professors at University of Miami, who dropped this phrase that every patient's a cardiopulmonary patient. Everyone's got a heart, maybe at least one lung, and every time you move them, it's a mini stress test. And then when you break down the physiology, as far as like what common interventions we do in a clinic, as far as squats or shoulder scaption or something like that, you look at the hemodynamic changes, you can see up to 60 to 80 point increase in pressure, and then you look at epidemiologically, hypertension, heart disease are our top killers, and we see patients that fall within those demographics more often than not in outpatient orthopedics specifically. Because when you look at the risk factors for low back pain and osteoarthritis, they're almost identical. They're almost identical to the ones for heart disease. And why we choose to ignore that is just beyond me. So it's just looking at the statistics, looking from my own clinical experiences, and just having some pretty great mentors and professors, Dr. Cohen and Dr. Cahalan specifically at the University of Miami. So that's what kind of led me into here. But yeah.
Fantastic. So when a patient presents to you for an initial evaluation, what are the measures and objective findings that you collect across the board, irrespective of the situation?
All right. So for every single patient, whether they're a 12-year-old, ankle sprains, a 65-year-old with low back pain, anyone on that spectrum, I do at least a resting, heart rate, palpated manually, and blood pressure, auscultated with a stethoscope. And I do a quick, murmur assessment. As long as if you're taking their history and asking them, just clearing out chest pain or dizziness or lightheadedness or anything like that, and getting their resting pressure and getting a feel for their, it's key that I mentioned too, that you do these things manually. Assessing, heart rate on a pulse oximeter, it's great because it gives you the pulse ox, it gives you the heart rate, and it's fairly consistent for that. But you miss the ability to perceive how regular the rhythm is. and you can often catch something. And very, very likely when that patient goes to their physician or any other provider, they're not assessing it manually. They're assessing it, again, pulse oximeter. So you may miss an arrhythmia, and it's an opportunity to catch it, and it takes 30 seconds to do. And all you have to do is, see if it's regular, if it's beating one after the other, or if it's skipping a beat, or if so have you. So there's that, and then auscultating the pressure, with a stethoscope, because there's a myriad of reasons why an automated cuff can be wrong. And the gold standard is auscultating it. And again, it's a simple skill that we all should be able to do. And then key questions, asking the patient, do they get short of breath with walking? We always ask about, what's their, how well can they bend over? Can they go up and down stairs and stuff like that? But asking them, how long do they walk? Are they regular exercisers? And again, kind of going to typical exam questions we'd ask and giving you that kind of cardiovascular focus is asking you, do they get short of breath going up and down a flight of stairs? If someone can go up and down a flight of stairs without any issues, without stopping for fatigue, they're probably fine. If you look at the CDC kind of guidelines, that's about 5 METs. And if they can tolerate 5 METs roundabout, they're probably fine for you to proceed with physical therapy interventions. So, it's taking a history, taking a good, resting vitals, I think gives you enough. Now, granted, I have a little bit more advanced training, so I can kind of delve more into some more specific stuff. But as long as you're taking vitals, I think you're doing a service to your patient, and you're doing a lot more than we do typically in outpatient clinics. And kind of with that, if you think, what happens when you go to your doctor's office? Just kind of, they take your blood pressure and heart rate, right?
Sure.
Right. Do they have you move?
No.
You sit in the chair the whole time, right? You sit in the chair, you don't do anything, and they're taking it, right? And and let me ask you this, what's the symptoms for someone walking in with a blood pressure of 170 over 95?
I wouldn't. My mind wouldn't go to any particular place.
Because they don't have symptoms.
Yeah.
Hypertension, unless someone is completely in a crisis, which is when they're having organ failure, and they're probably not coming to your clinic, is completely asymptomatic. So you can completely miss something. And like I said, if you're running someone through exercise, through movement, you could put them at risk. There's a lot of studies that suggest pressures that exceed over 240, you could risk vascular damage. And who knows if they have underlying cardiovascular disease on top of that hypertension. So it's the whole thing. We want to be direct access providers, yet we ignore the most. Everyone thinks cancer, gotta screen for cancer. Well, that's great. Cancer screening without a biopsy or imaging is kind of tough to do. There's some good questionnaires you can utilize and some tools that have been developed. But cancer is still, it's a leading cause of mortality. Heart disease is much higher, and we can very easily objectively assess it. And we just completely ignore it. It's the whole thing. If you want the job, you got to wear the pants. You got to screen heart disease, and it takes such a simple thing to do. And then you think about how do we, as far as dosing exercise, that's been a hot topic for debate in orthopedic populations as well. How do you dose exercise appropriately if you don't know, what the response or the stability of the heart rate of the cardiovascular system is? It's just, you wouldn't just haphazardly give strength training, right, without knowing how much weight they can move. It's the same thing with the heart. There's a vascular response, there's a hemodynamic response. So it kind of goes into that. So sorry, a little bit of a soapbox, but yeah, that's kind of how I go about it in my thought process.
That's great. And the point that you highlighted, I do think that most of the time when people are screening for red flags, they invariably think of cancerous processes, and there's a whole other slew of things, as you alluded to, that just sort of get brushed by the wayside. So what are some of the specific red flags that you would just absolutely refer someone out right off the bat?
Okay. Well, the most basic ones, again, is if someone has a resting pressure over 160 over 190, and there was an article by Susan Scherer out of 2005 in JOSPT, actually, on her algorithms for when to determine someone's appropriate or not for physical therapy interventions. And I believe her cutoff specifically is 160/90, which kind of falls in line with the ACSM and AHA guidelines for resistance training. And you think kind of a lot of what we do in PT is a lot of resistance training. So if I detect a regular rhythm, and if someone is intolerant to stair climbing, I don't necessarily it's somewhat so like those referrals I wouldn't hold therapy. And again, that's more up to your comfort. I wouldn't do any interventions with them that day, and I would get in contact with their primary to get their pressure medicated or controlled a little bit better. Detecting an arrhythmia is one of them. Again, you necessarily wouldn't stop therapy depending on what you're comfortable with managing. And then detection of a murmur. And I don't know what your education or training was, at Delaware as far as assessment, and I found across programs that level of training it could be better. A lot of programs don't even touch on them, murmur detection or what you should be listening for. So that's a big one. So.
And are there specific populations that you really sort of your level of concern may increase?
Say that again?
Are there any specific populations that you're particularly concerned about, or that you're just really strict, beyond, say, what you typically are, that present you on a daily basis?
Yeah. So I kind of look at it this way: if someone shows them up to my clinic, say they're hypertensive, say their pressure's 160/95, it's high, right? But they can go up and down a flight of stairs. They don't have any other symptoms, no chest pain, no dizziness, no lightheadedness, no murmur, no rhythms regular. I'm probably fine. We'll go about. We'll just closely monitor. If they're showing more and more symptoms and signs, they have a murmur with hypertension or an arrhythmia with hypertension, then I may be probably not going to do too much. And again, patients with risk factors like diabetics, the elderly, severely deconditioned populations too. You're probably a little bit more cautious. The ACSM has published pretty good guidelines on risk, people who should get screened out with an exercise test prior to exercising. And so I kind of use those primarily for patients who I'm a little more concerned with. And then we'll probably investigate things a little further. So, yeah.
Okay, that's all great information. Is having a beard like yours a risk factor for anything?
Probably is. And we'll find out in 50 years. Yeah, I don't know. Yeah.
One of the things that I've become very interested in lately is I spend a lot of time around these very high-level cyclists, and they spend so much time, and I know we're switching gears quite a bit here, but they spend so much time doing breath training, especially using this Power Breathe device. And full disclosure, I don't get anything for bringing that up, but it's fascinating. And I never was exposed to it before. I mean, obviously, I know breathing's important as an endurance athlete, but they spend so much time training their breath. And I just wanted to see if you could shed some light on that and why that's important, especially from a performance standpoint.
Oh, absolutely, absolutely. So it's interesting because in the cardiopulmonary world, like I don't say that's my primary area of focus. This has become we use this for a lot of patients, especially patients with COPD or any lung conditions. It's made its way into orthopedics, into performance, basically because we know the basic premise is, with exercise, especially endurance exercise, high level stuff. Typically your lungs never fail you, right? Your lungs have such an impressive, massive capacity. The surface area is like half a tennis court, right? Tons of room for ventilation. So in someone who's very endurance trained, they probably have peripheral adaptations. Their muscles are probably pretty good at extracting oxygen. So what may fail them If their peripheral muscles don't, is their diaphragm primarily, your inspiratory muscles, your respiratory muscles, your diaphragm comprising 75% of that effort. And there's even been several studies that demonstrate acutely after a marathon, like a patient's maximum pressure they can inspire with, and maximum pressure they can expire with, and the amount of volume they can pass in a minute will decrease relative to the resting values post marathon or post cycling. So there is a degree of respiratory fatigue, and then those respiratory fatigue measures have been correlated pretty strongly to I guess you can even say causative to decreases in performance. So their fatigue time gets if your respiratory muscles fatigue, your overall performance or your time to overall fatigue decreases. So you get fatigued faster when your respiratory muscles fatigue, which makes sense. So there's been several studies in like rowers, cyclists, and marathon runners that have demonstrated training protocols where they're about 30% of their training at about 30% of their max pressure, have demonstrated, of course, increases in their their ventilatory measures. And I always do this with my hands, kind of moving it, simulating a diaphragm, but your diaphragm gets a little thicker, it gets a little more fatigue resistant, and their performance overall improves. And the idea is, if you're, at high level sports, and you've noticed, you've run several, marathons and Ironmans, and quite competitively. At high levels of sport, the margins for improvement and success are so thin. If you can give an athlete a little bit of an edge, you can have huge improvements and gains. So that's the idea behind it. Just finding areas that are weak and trying to improve them as much as you can. And the diaphragm, like I said, it's not an old, inspiratory muscle training is not an old concept. It's just getting, or not a new concept. It's just getting more into this field. But yeah, it's pretty simple to do too. So.
And it's really fascinating. All of your comments sort of echo what the owners of the bicycle shop say. And so we do a lot of Moxie testing, which is basically looking at, it's a new way that's sort of going to replace lactate threshold testing.
Oh, really?
So yeah, and it's really fascinating, and it relies on these infrared sensors, and we're putting them on the vastus lateralis, and it's basically dealing with tissue impedance. But so this is a progressive test, so you start at a certain power output, and you basically take someone to failure. And one of the owners of Harriet Sports Performance, David Richter, he always says that most people's limiting factor is not their musculature, it's their inability to breathe properly when they get into these higher workloads. Yeah. And after he gets folks doing a breath training protocol, really an inspiratory training protocol, they'll come back, whether it's 6 months, a year later, and wildly different numbers in terms of improvement. So it's really fascinating. Like you said, this is something from a performance standpoint that people probably don't focus enough on. And it also seems, with the diaphragm, it's, part of this is functioning for stability purposes, and then the other, portion is really for breathing sake. So it seems like there's got to be a little bit of a tug of war there.
So interesting you mentioned that. There's been several studies by Pavel Kolar, he's a Polish guy, and I think he's based in America now, and Lottie Janssens, who looked exactly what you just talked about. And I gave a lecture at UIC and did a webinar, or not a webinar, a brief interview with Rick Daigle on this. So like you mentioned, the diaphragm, we know the anatomy, it has attachments to the upper lumbar vertebrae, right? It forms a synergistic relationship with the pelvic floor, the multifidus, and the transverse abdominis to stabilize the trunk. This is all kind of stuff we've known in exercise physiology for many, many years. That this role occurs in strength training populations, especially in the Soviets would train their athletes to use the Valsalva to maintain, to shorten the diaphragm, or flatten it, which is contracted state, to stabilize their trunk so they could tolerate large or greater loads during squatting. But we've demonstrated that patients with low back pain have weaker inspiratory muscles, specifically the diaphragm, and are more reliant on ankle strategies versus trunk strategies because that synergistic relationship's dropped. And along those same lines, if you train the diaphragm using those IM inspiratory muscle trainers, their back pain can improve. So, again, like it's probably not the first thing you go to if treating a patient with back pain, but if you're not having success, with your conventional, treatments, manual therapy, or movement biases or whatever you want to call it, wouldn't be a bad area to look into. And the assessment's really easy. It's not invasive. They breathe into a tube. It's within our scope of practice, and it's something they can do long term. It's really, really easy to do. And kind of like we were saying, it seems that patients, when you look at populations like patients with COPD, who have impaired diaphragmatic function, like you said, there's a dynamic interplay between its like respiratory function and its stabilizing function, and there's a giving point to some degree where it won't be able. It's got to keep you alive. It's got to keep you breathing. So it'll lose some of that stabilizing power or function. So the diaphragm's a pretty awesome muscle, and we're learning. It's kind of like how the pelvic floor is now ignored, and now is a hot buzz topic, and the diaphragm's kind of going that same route. So
yeah, which is great. So I'm learning a lot just from this discussion. It's giving me sort of a refined understanding of things. Something I've been fooling with the Power Breathe is setting the rhythm to a metronome. So I'm doing it at 30, 45, 60 beats a minute. So that way, depending on what pace I'm running at, or how intensely I'm cycling, that I sort of have this larger range. So again, that's not based off of any literature, but it's just there is a rhythm and coordination to it that is something that you definitely acquire with practice. And to see folks who have been training in this manner for a decade is just unbelievable. I had mentioned before we got on the talk here that this fellow is able to work with a 5-liter bag, and he is not a big guy. I mean, he's under 140 pounds, and he's one of the top cyclists in the country. And it's impressive to me. I feel like I have pretty good, cardiovascular function. He just makes me look like a complete amateur. So yeah, interesting stuff. So one of the things that was really getting a lot of press, and I think it's still obviously receiving a lot of attention, but maybe 3 to 4 years ago, we started seeing a lot of people in the sport of triathlon, namely in the swim, that were winding up dead.
Yeah.
And there's a lot of factors, having done these open water swims and triathlons. I'm sure, again, it's sort of multifactorial. Are there any things that come to mind or that you think were driving some of these deaths in the sport?
So the most likely cause is what we see a lot in these cases, these causes of spontaneous deaths, especially in these really high trained athletes. I think a term we call, or a diagnosis of sudden cardiac death. The cause, of course, of that death is typically some form of arrhythmogenic origin. So usually, VFib or a high AV node block or something of that nature. The cause of that arrhythmia will vary by age. In older populations, it's usually just some kind of atherogenic lesion. So you have a blockage somewhere in the coronaries. You have a supply-demand mismatch in the heart. When that happens, the heart becomes more ischemic and it becomes more prone to arrhythmias, and they die. And then in younger athletes, people under 35, the risk of death is more due to a structural abnormality, either in the ventricle, such as hypertrophic cardiomyopathy, or abnormal left ventricle hypertrophy, or an abnormality in the coronary arteries, called a CAA. Most commonly, a myocardial bridge is where the coronary arteries, as we know, kind of like, run on the surface of the heart, and then have smaller branches which go down into the smaller capillaries which go into the muscle. The myocardial bridge, that coronary artery like goes through the myocardium, and we know when you contract, that would get constricted, which would reduce blood flow and would cause ischemia downstream. So that's typically what we're seeing at some of these causes. The problem is it's screening for that, depending on where you're at, is completely different. And I really think we do ourselves in this country a big disservice on how we screen things. And when I can talk a little bit about that in particular. But so in Italy, so I'll talk about in the States currently, prior to athletics, we'll do what the AHA calls a 12-point assessment, which incorporates like family history, the patient's report, they're screening for like syncope, chest pain, and a bunch of other symptoms, assessing for Marfan syndrome, which is another risk factor, especially in pediatric populations, and then assessing for murmurs, and that's pretty much it. The person clears those out, they're ready to go and do sports. Excuse me. The issue with that is there's been several studies that have examined this 12-step like screening, and they've noticed that though murmurs, if it's detected, it's pretty indicative of there's some kind of structural abnormality. The issue is it's a skill. It's I wouldn't say a qualitative skill, but your ability to detect changes is relative to your experience in doing it. So it's not as consistent between providers. And then very often do patients with structural abnormalities, they don't report any symptoms. I mean, there's famous cases. I mean, these guys, perfect example, you mentioned these endurance athletes. These guys are like the pinnacle, of health or of exercise capacity. Had no symptoms potentially, right? So they're not going to report chest pain. They're not going to report syncope, and even if they did, syncope is pretty common post sports, even with people who are completely healthy. So you throw all those factors in. Is that screening really that useful clinically? Does it really tell you anything? So Italy, since 1982, has done this kind of the same 12-step approach, but everyone before any sport at all levels gets a 12-lead ECG. The 12-lead ECG is great because you can make decision trees off what you see. An ECG it's quick, it's cheap. It costs like $20 to do an ECG. You can think of how expensive is a mammogram, and everyone above 55 for women gets one. Like, it's just what is done, and it's way more expensive than an ECG. It has pretty high false positive rates too. With that protocol in Italy, they've have noticed a 90% reduction in like an SCD. So their screening's way better. They don't overutilize. The thought was, well, they're going to overutilize. They'll have high false positives. They'll send the athlete down this pathway of not being able to play their sport. And if they're a pro athlete, it's a big concern because they're making money off of that. Or you're racking up unnecessary testing like an MRI, cardiac MRI, which would be indicated, an echocardiogram, which would be indicated, and other testing measures. And that they found it's not the case. They're pretty effective at screening things out, and the things you're really concerned about are really easy to detect with trained eyes on a rhythm strip, on a 12-lead ECG. And the AHA has passed guidelines saying, well, that's kind of hooey, and basing it off these older studies from like 2005 and 2010. And I don't know if you're familiar with the Seattle guidelines.
No, I'm not.
So it's these group of doctors, cardiologists in Seattle, published these guidelines, which makes it a little bit more specific to being able to determine what's abnormal and what's normal, because there are some normal physiological changes you see with endurance training. You'll see those sinus bradycardias. The heart rates get really, really low because their heart's so well conditioned. You may see an AV node block, a type 1, even up to a type 2 Mobitz 1, which are asymptomatic and kind of benign. And we call sinus arrhythmia, which just means a higher vagal tone, but the ECG complex, the QRS complex, looks normal. So you do see some changes even in normal populations, but there's certain particular diagnoses that you see on this ECG that would rule a patient out completely. And it's safe, it's cheap, it's effective, and we don't do it here. And it blows my mind. It really does. So.
Well, you'll have to be the impetus behind that. You're obviously going to be stepping into a position where you're going to have a lot more say and authority and time. I mean, based on just our discussion right now, I mean, I wish you could just hang with me in the clinic to find how I'm working with patients. So again, switching gears, if someone's going to start picking up the sport of running or triathlon, are there any key metrics that you think they should be paying attention to, whether, obviously perceived exertion, but, do you recommend people to always monitor their heart rate? What are your suggestions on that front?
So before anyone starts any marathon training, I granted it's not within the AHA guidelines. You may have to push your primary to do this, but I would recommend getting that 12 lead ECG to start, just to screen that out, and seeing your doctor, seeing your physician, to get your resting measures, and then of course and gradually progressing your mileage, and of course tracking heart rate, which would be a great thing. In addition, as we know, with overtraining, which is unfortunate, but it's a great kind of cash flow for us. But overtraining, you can monitor that by if the patient has an elevated heart rate response, up until the day after training, it could be a sign of they've pushed it too far. So that heart rate training, heart rate assessment and tracking would be a great measure for your novice runner. But the key impetus is really getting a baseline screening. Just make sure you're clear, especially if you're over the age of 35. Definitely get it screened out.
Yeah, I think that's something I always encourage people to take their resting heart rate in the morning. And there's some interesting technology that I'm sure you've heard of, the Omega Wave.
No, I'm not familiar with that.
So from my understanding, it basically is working off of heart rate variability. What's the research show in terms of heart rate variability? I mean, can you demystify that for viewers?
Yeah, sure. So, I'm not an electrophysiologist, but I'm actually doing a study right now on heart rate variability. We've got a really good postdoc here, a guy named Danny White, who's like a guru in this. But heart rate variability is an assessment of your overall parasympathetic tone. So patients who have greater heart rate variability tend to be a bit better conditioned. And you typically assess it in 3 positions when the patient's, it's based through an ECG. And you assess R to R wave differences, which is the peak spikes. And it's a sign of improved parasympathetic tone, which is something you see in endurance athletes. That's why you see that that diagnosis or term of sinus arrhythmia in patients with endurance training. It's a response, or the heart rate variability is due to that. And why that happens, like we said, it's the increase in vagal tone. Some people say it's maybe there's some changes in structurally in the heart. And it's also been something that's been explored in patients with chronic pain, and in response to thoracic manipulation or cervical manipulation. I'm actually in the midst of an IRB of doing a study right now. We got approval on assessing the neurophysiological response to thoracic manipulation, and by assessing that using heart rate variability, because the changes we know are pretty acute with manipulation. And a way to capture that would be ECG, which is instant, and beat per beat blood pressure, which we've got a pretty cool non-invasive measure. But heart rate variability is just, like I said, it's your heart rate oscillates over time, and it's due to increased vagal tone and it's more seen in highly trained athletes. So
Okay.
that's really what it is.
Yeah, it's very helpful. So so when I wake up in the morning, what would you encourage me to do? Sorry, this isn't a selfish question, but what do you think I should be paying attention to? Should I just basically be taking my resting heart rate, sort of a subjective assessment of how I'm feeling before I go out? Any other key things that you would recommend someone like myself or other triathletes, endurance athletes to collect on a daily basis?
Yeah. Well, again, of course, heart rate, their mileage, that's a good one to check too. Are they peaking or going down? Is there any persistent swelling too? We're noticing, and the literature is conflicted to a certain degree over this, over the structural changes that occur in the heart with endurance training. There's some research to suggest that there is an acute right ventricular dilation that occurs, as well as over time, you may see that change may become more permanent than reversible, as well as a left ventricular thickening. And it's just because your heart's a muscle. So, if you load it constantly with blood, just what you're doing when you're running, it'll make adaptations. Without having any kind of, the only way to really assess that is, again, by murmur, which not everyone's going to be able to do on themselves, or having some kind of an echo or something like that. But tracking your heart rate for resting rate and your rhythm, especially again in patients over 35, you may see, so patients who have endurance trained for longer, for a long part of their life, who are over 35, have a high risk of developing atrial fibrillation. Why that happens, we're not really sure. We think it's because they have a lower sympathetic drive at rest, that higher vagal tone, and they, of course, during exercise, your sympathetic response increases because it's kind of the way the body works. And I think that change in the interplay somehow affects the conduction pathways. So assessing if there's any irregularities developing with your rhythm, that's a good screening tool you can use. But again, as long as you're checking your heart rate, if your mileage isn't decreasing, if you're not noticing any increase in swelling up into a few hours afterwards, and if you're not developing any lightheadedness or dizziness or chest pain during activity, those, you're probably okay to continue. But again, screening at the onset is probably the biggest key.
Okay. There are some other really interesting just behaviors among runners and triathletes. So, one of the things I always tell folks is after an Ironman or after a marathon, to definitely avoid flying for at least 24 hours because, a lot of times people fly in on a Friday, race Sunday, try and fly out on a Monday. Do you have any words of wisdom or pieces of advice along those lines?
I don't know the research out there or anything to support that or not, or to refute it. I would just empirically, I would recommend that as well. Like, if you think of kind of what you've just done to your body after a marathon or an ultra marathon, you need a little bit of rest. And flying in itself is stressful. You're not moving. And again, like we said, there may be some changes to the right ventricle. And if you're sitting, for long periods of time, there could be, risk for venous pooling and other issues like that. So, I think resting for a day wouldn't be a bad idea, just to kind of let your body recover. Depending on how long you ran for, you could put, I don't want to use, I hate using the word trauma, but it's kind of what you did to your body. So just give it a day or two.
And along these same lines, compression socks. I mean, is that something that, is there any research that's come out recently that talks about the role of compression socks, or are there any sort of concerns that you would have with someone using, say, like basically compression socks that are coming just below the knee?
Yeah, to my knowledge, I don't believe there's a lot that supports it. Again, there's not a lot to support kinesio tape either, and everyone does that. So I don't think it runs your risk for, like, you're not going to develop a clot, especially in someone who's, running, 60 miles a week or whatever your training program is. It's probably not going to happen. I don't think it provides that much of an added benefit. Maybe in like ultra marathon runners, the key concept is behind these compression stockings is that you got the skeletal muscle pump, right, which helps kind of shunt blood back up to your heart, helps maintain cardiac output with respect to a given workload. And the idea is you give it a little bit of an assistance by that compression to help shunt blood, so your paratibial muscles like don't fatigue as much. That's kind of what I've been told. Does that make sense intuitively? Yeah, to a degree. Does that make too much sense physiologically? Probably not. If you're, and my whole thing is too, if you're reliant on like kinesio tape, if you're reliant on, these like stockings, like, should you really be running those distances? And you see it more often than not in the average recreational runner versus like a high trained person, someone who may need it if they're doing like, ultra endurance running. But, I don't think it's going to be to your detriment, but I don't really think it's going to give you much of an added benefit. And I'm not a runner by trade. So I can't, give you too much or any anecdotal feedback on it, but what's your experience? Have you utilized them, Chris?
No, I really don't use them. I mean, it seems like just one of these trends that comes and goes. So, still when I show up to the start of an Ironman, a lot of people, even at the days leading up to the race, post-race, most folks are in them. I would imagine that the ones that are closed toe would be the best. But again, a lot of this stuff makes sense on the surface, but I haven't seen any research that has been that impressive where I'm going to run out to the store and buy a pair, because they're very expensive.
They are.
They're not quite as expensive as a medical grade compression, but it's a step down. So yeah. I don't like people to throw money at any of their problems. But people say, look, I like these. They feel comfortable. I don't fight with them over it. So
they look cool. Yeah, they look cool.
Yeah.
Right?
Yeah, like you said, trendy. It's fashion. Day's end. Yeah. So, one of the things that it's probably still present. I don't know how pervasive it is, but can you talk a little bit about EPO and just some of the things that surface along those lines?
Yeah. So one thing I want to talk about in particular are the usage of beta-2 agonists. Now, you may ask, what in the world is a beta-2 agonist? Now, if you remember from your basic physiology, in pharmacology, your beta-2 agonists or your beta-2 receptors would line primarily the linings of your bronchial tree. When they're stimulated, they dilate, more ventilation. When they're inhibited or blocked, they constrict, decrease ventilation. Beta-2 agonists, or help, again, keep them dilated. They're used for patients with asthma primarily, particularly in acute bouts and flare-ups, and in patients like COPD and asthma. So what's come under scrutiny is the abuse of them to a certain degree. The research is conflicting, again, like on most things, on what they actually do as far as a performance edge. They're a banned substance by the IOC and some maybe the USATF or ITF, right? It's one of those listed of banned substances unless you have a doctor's prescription. What the interesting thing is, you see, which I find it hard to believe that exercise-induced asthma is one of the most commonly ordered or commonly diagnosed conditions in Olympic athletes, endurance athletes, which blows my mind because that's not something you would ever expect. I have exercise-induced asthma, and I'm no Olympian, but it's very common. And the thought in some circles is that it's diagnosed to be able to take these drugs And the thought is, again, if you take these agonists, these inhalers, they help, maintain the airways. They're a little bit more dilated. It acts as a stimulant as well. And if you take it orally, and that's the thing they're concerned about, because the ventilators, inhalers don't seem to have as much of an ergogenic effect. But taking it orally through like a liquid form has been shown in some cases to increase lipolysis, or breaking down of fat, which in endurance athletes, you're burning a ton of that. So the more substrates you get available, it could give you a boost. So there's been, and that's why it's banned. So, and then you think, why don't do all these athletes you'd never suspect to have this diagnosis to have it, and they think maybe it's to allow them to use these aids. EPO and blood doping, name the year. There's probably some cyclist somewhere abusing, whether it's EPO or ephedrine or some other substance. The idea, of course, is you get more red blood cells in your body, increases your carrying capacity for oxygen, and of course your ability to clear metabolites during exercise. The problem is with that, again, it's illegal, but wildly illegal in these circles. It's dangerous because if your blood becomes more viscous, your risk for clotting is a little higher too. So it's not safe, you question the ethics of someone and the standards of a physician who would do that. So as far as the safety of that being administered to you, and then but then you think about at the core of this, why does this happen, and who does this happen most often to? And if you look at it, it's more often the up and coming athletes, because you're Lance Armstrong is a bad example, but you're like pro athletes who have the contracts and sponsorships are able to go train in like the Andes, or able to go train in the Alps where there's elevation, where they can make these adaptations naturally. Your up and coming athlete doesn't have that, so they got to find a way to like get that edge to get up there. There's been a lot of population studies, but assessments in high school athletes taking steroids, anabolic steroids, to get them into Division I or into pro contracts, and stopping using once they get there, because there's a rat model that was published in the benefits from steroids can be seen in short cycles of usage, and the gains are maintained up into a year, and I think 5 years post using. So
wow, I didn't realize that.
Yeah. So the thought process was like, if you got to keep taking them, and what we're learning now is that may not be the case, and so a few people may have gotten slipped through the cracks, because in high school I think like Texas and California and maybe Florida are like the only states that like do blood testing for steroids in high school sports. They're like the only ones. And you think there's 50 states in in the district, and they all play sports. These kids taking steroids, to get these scholarships to perform better, to train harder, and then they stop when they get to college. There's also, and the issue is there's always going to be more money in doing things illegally versus doing it legally, and it's just catching it. But that's a whole can of worms with performance abuse or substance abuse or.
Well, hey, look, I really appreciate you. I mean, we covered so much ground there, and as I mentioned before, you're a wealth of information. Tell us a little bit about what you're looking to do with your PhD, in terms of what your focus is right now in terms of research, and ultimately what you'd like to be doing.
So the PhD I'll be starting is under it's the rehab science PhD here at UIC. It's our first year of starting this particular program. My PI is a guy named Shane Phillips, or Dr. Phillips. So a very well acclaimed researcher and educator here at UIC. The topic or my focus again will be more cardiovascular physiology. Shane does a lot of stuff on diet, particularly in patients with diabetes and heart failure. but we're starting a huge project within the VA. One it's based out of Pittsburgh, based out of Baltimore. Now we've been recruited to kind of help with that, investigating aerobic training, resistance training, and inspiratory muscle training in these populations, and assessing them for mortality risk, exercise performance, typical measures you see in populations. We're going to do some biopsies of skeletal muscle biopsies. So that's going to be like a big part of my research for this program. But additionally, I'm interested, like I said, really getting cardiovascular physiology and orthopedics to really merge. Particularly trying to get more or further explanations of what happens in some of the interventions that we do and how to make them the most safe. Because I want to see us as direct access providers within the next 5 years, like unremitted. Like, I could go off of my political soapbox, but chiropractors have been direct access providers for decades. And I think our standards of training and safety is as effective or more, and we don't have it. And I think a lot of it is going into like getting proper screening measures, endorsed by the APTA and endorsed by other professional bodies. And I think a lot of it's for me, it's going to come from the cardiovascular section. And we'll be rolling out a study, like I said, assessing. We're in recruitment for a study investigating the hemodynamic response to thoracic manipulation. We've got another survey study coming out to assess what providers are doing in their clinics, and what they have available. And the idea is I got to find out what people are doing to determine like how do we, what needs to be improved and how do we go about improving it. Because if you say, well, everyone should be checking blood pressures, but not everyone has a blood pressure cuff or knows how to take one. It's a different intervention based on that problem. So we've got a listserv within the orthopedic section that we're going to utilize to send some of that stuff out. So if you guys are watching this, may see an email from some idiot from Chicago asking you what you're doing to assess blood pressure. But so that'll be coming out. And then again, we're hoping to have a presentation on this at CSM, a group of us, Chris Ritchie and Matt Lee out of Kentucky, looking into this and trying to get more people I wouldn't say interested in this, but doing this and seeing the clinical applicability of this. Because these guys out of Kentucky have got some great data on their utilization and screening and referral generation too. Because you think like if you're referring docs, feel like you're safe with their patients, or you're doing I wouldn't say above and beyond, which it really shouldn't be above and beyond care. Like they're gonna want to send their patients to you. So there's a lot that goes into it. So again, I'm going to be doing a lot of basic science, clinical science, and then some I don't want to say advocacy, but like utilization studies. I teach a little bit. I taught the cardiovascular and pulmonary dysfunction course here at UIC. So hopefully a bit more of that. I love teaching, running the website, and trying to maybe find some sleep in there at some point. So yeah.
Yeah. Good luck. Good luck.
Yeah. Yeah.
Well, hey, look, this has been awesome. And, anytime you're out in Seattle, I would love to give you a platform to present to all the endurance athletes that I'm connected with out here. They would really benefit from having someone with your expertise. And the Physical Therapy Association, the APTA, should just be ecstatic to have you involved in just spearheading a lot of this stuff. I mean, I feel like you have such a pulse on this stuff. Your research is spot on. And I look forward to reading it and seeing what you're up to over the next several years. And the crazy thing is you're relatively young too, Rich.
Yeah, that's nuts.
Yeah, so I mean, this is my first time connecting with you face to face. So I'm blown away, and I know there's a lot more I can learn from you. So I'm gonna run this through social media, and again, I can't thank you enough. So. Look, I know you're from Philadelphia. That's your only strike against you. So I think both of our football teams are in dire trouble. So
oh man, I don't even know where to begin. And by the time I check my phone, we probably traded another player. So
yeah, exactly. Yeah. So I haven't been keeping up with the hockey, but in any case, Well, hey, thank you so much. I want to chat with you a little bit once we end this. And any words of wisdom before? I guess it's 5 o'clock right now, so everyone's probably cutting loose. But any final words of wisdom?
Well, I'm going to do one thing before I leave. I'm going to throw up the U, of course, for my fans up there, and just throw off the UIC shirt. But right. One thing to remember, like I said in the beginning, every patient is a cardiopulmonary patient. Every patient's a neurological patient. Every patient's an orthopedic patient. And that applies to all sections. And I think within our scopes and within medicine, we get so, I don't say narrow-minded, but very focused on one area, one system. And, everything we do has implications. And we know this, assess these things. And and like we've talked about and demonstrated, they have implications in your treatment. So always remember that, every patient's got a heart, got maybe at least one lung, and every time you move them, it's a stress to the system. And that exercise is not just a mechanical stimulus. It's not just a response of the tendon and the muscle. When you move an arm and you move a leg, the muscle, of course, responds, the tendon, of course, responds, but there's also a vascular response. You compress the vessel, you cause active hyperemia. The nerve has to glide. What does that do to the sensitization of the nerve? Skin has to move, fascia has to move. There's all these responses. Don't just focus just on the muscle and the orthopedic system. Think, holistically of what's going on in the body, because we're learning more and more, especially with blood flow restriction training. Maybe the muscle metabolic response, is causing some of these changes more than just, a load response. There's a psychological response to it. I'll leave you with one last quote. The truth defies simplicity. And that's kind of, I would say the core motto of mine or credo of mine is, we as humans try to compartmentalize things, make things as simple as possible, but very rarely are those simplifications true. And if you kind of always bear that in mind, and be inquisitive of what exactly you're doing with the patient, I think your level of understanding, your appreciation for the care that you're providing, and what you're doing will be further enhanced. So,
well, that all sounds spot on. And I spent close to a decade at the Nicholas Institute of Sports Medicine, and had a chance to get to know Dr. Nicholas Sr., who is considered to be one of the founding fathers of sports medicine. And when this is a first hospital-based sports medicine institute in the country, and when we used to have these roundtable discussions, it was amazing. You'd appreciate this. There was a cardiovascular doc, there was a neurologist, there was an orthopedist, there was an internist, there was an endocrinologist. There were just all of these people from different disciplines of medicine that were coming together. And that's something, like you mentioned, we don't see that as much. And, things have gotten very compartmentalized. So, that's one of the nice things about combined sections where, you start wandering around the abstracts or going to different platform presentations, and you get to see everything coming together, and you realize how complex the system is.
Yeah.
So, again, like you said, the truth defies simplicity. I think that's very well said. So, I don't know if I can quote you for saying that, but
yeah, I heard it somewhere.
Yeah,
I heard it somewhere.
There are a few quotes along those lines. So I'll never figure out who said it. And hey, look, I hope when you get your PhD, the beard is sort of like ZZ Top mode. So
I'm probably never gonna get longer than this, but I like it, man. And being, you mentioned, I'm pretty young, and I'm teaching a course of kids. Like some are, I don't say kids, but some of the students are older than I am in this PT program. I'm like, it makes me look a little older. So
and respect, and just speak a little bit slower when you have to drive home points, and just start grabbing your beard.
Yeah.
Any case, hey, thanks again. Have a great weekend, and I look forward to connecting with you in person.
Indeed.
All right, signing off.